Hello everyone, I am myself Dr. 𝗑𝐲𝐫𝐞. I am the general medicine educator. So in this session, I'll be discussing the important questions in the toxicology. Like these are the questions which have been asked in the recent UPSC exam related to the general medicine. So I'll not be just discussing only the previous year questions, and I'll also be discussing in detail about that particular question in and around that particular topic, right? So the first question is, early hypotension in venomous snake is due to which of the following? Pooling of the blood in the pulmonary and splanchnic circulation, systemic bleeding, hemolysis, loss of intravascular volume into the soft tissue. So the reason or the mechanism for the development of hypotension in case of venomous snake bite, that is due to loss of intravascular volume into the soft tissue. Now this particular mechanism is what is responsible for the hypotension, and because of which the perfusion to the organs will be reduced, right? And these patients will have this leakage, that is mainly because of increased permeability and as well as leakage of the plasma into the surrounding tissues. Now if you take these venomous snakes, we have two important forms of snakes. One is hematotoxic snakes, the other one is neurotoxic snakes, and we also have the myotoxic, but mainly we have the hematotoxic and as well as neurotoxic snakes. What do you understand by this word hematotoxic snakes? That is, the hematotoxic venom, it primarily affects the blood and blood vessels, and because of that, in case of hematotoxic snakes, there will be coagulopathy, there will be hemorrhage, there will be tissue damage. So these are the effects of the hematotoxic snakes: coagulopathy, hemorrhage and tissue damage. Now what are the examples of this hematotoxic snakes? That is mainly vipers and as well as some elapids. And what are the examples of these particular vipers? That is rattlesnakes, Russell's viper, saw-scaled viper and gaboon viper. These are the Viperidae family. They are mainly hematotoxic, but some elapids, they are hematotoxic. Examples: the tiger snake and as well as the brown snake. Now followed by these hematotoxic snakes, the next important example like what we have is neurotoxic snakes. What do you understand by the word neurotoxic snakes? They are the one which primarily affects the nervous system, and thereby there will be paralysis, right? Thereby there will be paralysis and other neurological symptoms. Now what are the examples of these neurotoxic snakes? That belong to the Elapidae family and as well as some sea snakes. Now what are the snakes belonging to the Elapidae family? That includes cobras, kraits, mambas, then coral snakes and taipans. These are the snakes which are belonging to the Elapidae family, which are neurotoxic snakes. But some elapids, they are hematotoxic. Example: tiger snake and as well as the brown snake. And some sea snakes which are neurotoxic are beaked sea snake and yellow-bellied sea snake. So these are the neurotoxic, and some snakes are mixed toxicity. That means they have both hematotoxic and as well as the neurotoxic effects as well. The example are the king cobra and as well as one more rattlesnake, that is Mozave rattlesnake. So these are the ones which have mixed toxicity, both hematotoxic and as well as the neurotoxic effects. So that is about the points related to the venomous snake, and the reason for the hypotension is mainly due to leakage of the blood into the surrounding tissues, right? Next question. Gastric aspiration and lavage is contraindicated in which of the following poisoning? Strong acids, alkalis, petroleum distillates and as well as the ethanol. So please remember, strong acids, alkalis and the petroleum distillates, the aspiration and lavage, it is contraindicated. But whereas for ethanol poisoning, even though it is highly volatile, if the individual comes in early phase, right, within half an hour or 1 hour, then the gastric aspiration and as well as lavage can be done. But even for the ethanol also, after a prolonged period of time, it will be of no use, right? Now, so the answer is 1, 2 and as well as 3. Now let me just give you the examples of what are all the various toxicities or intoxications the gastric aspiration and as well as lavage is contraindicated. Number 1, the caustic substances. What are these caustic substances? These caustic substances, they include the strong acids and as well as the alkalis, right? Then hydrocarbons, example petroleum distillates, right? The hydrocarbons, that is petroleum distillates. Then volatile substances, example methanol, and another very important example is isopropanol, right? Isopropanol. Then sharp objects are large pills, right? In them aspiration and lavage is avoided. And those substances where there is high risk of aspiration, right? The individual who is at seizure risk, in them the gastric aspiration and lavage is avoided. And rapid onset toxins like certain nerve agents and substances causing rapid loss of consciousness, so in them, right, the aspiration and as well as lavage is avoided. And corrosive chemicals, in them also the lavage and as well as gastric aspiration, it is avoided, right? So now in these substances, then what is that we do? We give either activated charcoal, right? We give activated charcoal to ensure that the intoxication is reduced. Then supportive care, or we give specific antidotes, right? We give specific antidotes. So this will be the alternative treatment where the gastric lavage is contraindicated. Then you take the caustic substances, that is strong acids and as well as the alkalis. These particular acids, they cause severe burns, they cause perforation within the esophagus and as well as the stomach, okay? And when you do lavage, when there is strong acid, this will further worsen the injuries. And the same way is your alkalis also. Alkalis, they can cause severe tissue damage and as well as burns. And lavage can lead to perforation and increased tissue damage. So that is about the caustic substances. Then you take hydrocarbons, that is petroleum distillates. What are the examples of the petroleum distillates? Kerosene, gasoline and motor oil. These three are your petroleum distillates. There is high risk of aspiration during the procedure, which can lead to chemical pneumonitis. So that is the reason why whenever there is petroleum distillates intoxication, the gastric lavage, it is avoided because there is risk of chemical pneumonitis and other respiratory complications. Next is the volatile substances, right? So methanol and as well as isopropanol, they are rapidly absorbed, right? So in them the gastric lavage will be of no use. And same way your sharp objects or the large pills, in them also there is of no use, okay? These are all the various intoxications where the lavage and as well as the aspiration is contraindicated, right? And you take this corrosive chemicals. Corrosive chemicals, mainly household cleaners, they may contain corrosive chemicals that can cause severe gastrointestinal burns and perforation. So in them where who have consumed household cleaners, right? So in them who have consumed household cleaners, the gastric lavage, it should be avoided, okay? So that is about the story related to the intoxications where the lavage is contraindicated. Next question. Acetylcysteine is an antidote for which of the poisoning? Salicylate poisoning, paracetamol, tricyclic antidepressants and as well as the benzodiazepine. So acetylcysteine is the antidote for the paracetamol poisoning, okay? So that is mainly we give N-acetylcysteine. N-acetylcysteine, it is a critical antidote used in the treatment of the paracetamol poisoning. Now, what is the mechanism of action of this N-acetylcysteine is, the N-acetylcysteine, it acts as a glutathione precursor, right? It acts as the glutathione precursor. Now, what is the use of this glutathione precursor? Now, in paracetamol poisoning, there is an intermediate toxic substance which is being produced. What is the toxic substance which is being produced is NAPQI, that is N-acetyl para-amino benzoquinone imine. That is what is the toxic intermediate product, okay? Now this toxic intermediate product, it is detoxified by the glutathione. It is detoxified by glutathione. Now in paracetamol poisoning, like what will happen is, in paracetamol poisoning, there is depletion of the glutathione, right? There is depletion of the glutathione. Thereby, the toxic metabolite or toxic intermediate product NAPQI levels will increase. But whenever you give this N-acetylcysteine, this will act as the glutathione precursor and it will detoxify this NAPQI. So, this NAPQI, it replenishes the glutathione stores, right? It replenishes the glutathione stores and thereby it has the increasing capacity to detoxify NAPQI, right? And not only that, this particular N-acetylcysteine can directly bind to, right, N-acetylcysteine. This will directly bind to the NAPQI, reducing its availability to cause the cellular damage. Okay, so because it is binding to this NAPQI, right, this will reduce, right, this will reduce the cellular damage, right? So this helps in detoxifying the NAPQI independent of the glutathione. And next is the N-acetylcysteine will also increase the sulfate conjugation. What this N-acetylcysteine will do is, the N-acetylcysteine supplies the sulfate, which facilitates the sulfation pathway for paracetamol poisoning. This enhances the conversion of paracetamol to non-toxic metabolite, further reducing the formation of the NAPQI. So, by doing this sulfate conjugation also, the NAPQI levels will get reduced. Then the N-acetylcysteine, it also has the anti-inflammatory and as well as the antioxidant effects. Okay, so this is about your N-acetylcysteine various mechanisms of action. Now, you need to be aware of what is the dosing of the N-acetylcysteine. You need to give the loading dose. So actually, the supplementation of the N-acetylcysteine intravenously, it is a 3-step process, right, over a 21-hour period. What is this? You need to give loading dose, that is 150 milligram per kg over 1 hour. You need to give the loading dose, and that 150 milligram per kg over 1 hour, that should be diluted in 200 ml of 5% dextrose or appropriate diluent. Second dose is 50 ml per kg over the next 4 hours, and here you need to dilute in 500 ml of 5% dextrose. And third dose is 100 milligram per kg over the next 16 hours. So this is the 3-step infusion process over the 21-hour period for paracetamol poisoning. Now, whenever you are giving this N-acetylcysteine, what is that you need to monitor? The clinical monitoring and the duration of the therapy. The clinical monitoring is, you need to monitor the liver function test. You need to monitor the liver function test. And you need to monitor the coagulation profile. Right, you need to monitor the coagulation profile, and you also need to monitor the renal function. So these three are essential: liver function test, coagulation profile, and assessment of the renal function. So these three have to be monitored. Next, coming to the duration of therapy. The therapy duration may be extended if the patient has ongoing evidence of the liver injury. So the duration should be increased if there is evidence of ongoing liver injury, right? That is one point. Second, if there is persistent symptoms, right? If there is persistent clinical features, then also the duration of the therapy should be prolonged. And if there is elevated paracetamol levels, right, so even then the duration of the therapy should be prolonged. So this is about the N-acetylcysteine in paracetamol toxicity, right? Next question. A boy presents with the ingestion of many tablets of salicylates. Which of the following complication is likely to develop with salicylate poisoning? Hyperkalemia, rhabdomyolysis, prolonged QRS complex in the ECG, metabolic acidosis. Okay, so right, the question is most likely to develop. So salicylate is nothing but, it is acetyl salicylic acid, right? It is nothing but aspirin. So the individual most likely to develop metabolic acidosis. Now let me discuss in detail about the salicylate toxicity. So salicylate toxicity, it is often due to overdose of the acetyl salicylic acid, that is aspirin, right? And these patients can have wide range of symptoms and laboratory findings. So there can be acute manifestations, and some of them, their chronic manifestations are also observed. So you take the gastrointestinal symptoms. The gastrointestinal symptoms include nausea, then vomiting, next abdominal pain. These are the gastrointestinal symptoms, and there can be hematemesis also, where there is vomiting of the blood because of the gastric ulceration. Respiratory symptoms include the hyperventilation, right? Respiratory symptoms include the hyperventilation, okay? And this particular hyperventilation is the one which will be responsible for the development of respiratory alkalosis, right? And there is respiratory distress, and as well as the development of the pulmonary edema. So these are the respiratory symptoms. The neurological symptoms, that includes ringing in the ear, which is nothing but the tinnitus, right? Tinnitus. And there will be also hearing loss, right? There will be also hearing loss, and as well as dizziness, and the individual may go into a state of confusion, and there can be also development of the seizures, right? So these are the features, these are the neurological symptoms. Then you take the metabolic symptoms. There can be development of fever, there can be a profuse sweating, and because of the profuse sweating, the individual go into a state of dehydration, and there will be also hypoglycemia. And what are the renal symptoms, right? There will be renal shutdown, and that will cause oliguria, right? That will cause oliguria, and there will be also development of acute renal failure. Arterial blood gas analysis, when you do in a laboratory investigation, there will be metabolic acidosis, and in compensation to this, there will be respiratory alkalosis. And if you take the electrolyte abnormality in salicylate toxicity, that includes the hypokalemia. And not only that, if you take other important metabolic abnormalities, there will be also hypoglycemia, and followed by that, you take the anion gap, there is increased anion gap metabolic acidosis. And you need to check the salicylate levels, that will be elevated. Then what are the other tests? The other tests include, there is acidosis. So if you check the levels of the lactate, there will be elevated levels of the lactate, and there will be also coagulation abnormalities, where there will be prolonged prothrombin time, Then if you take the salicylate toxicity treatment, the initial stabilization, that is by airway, breathing, and as well as the circulation, where you need to ensure the airway protection, adequate breathing, and circulation, okay? And you need to have an IV access for fluid administration. Next is decontamination should be done with the help of activated charcoal, right? Decontamination should be done with the help of the activated charcoal. So activated charcoal, you need to administer within 1 to 2 hours of ingestion. And what is the dosage of this activated charcoal? That is 1 gram per kg you need to administer orally, but maximum how much you should give? Up to 50 grams, right? And the patient is alert and has an intact gag reflex. So in them, the decontamination should be done with the help of activated charcoal. Then the fluid and electrolyte management. So these patients, because of profuse sweating, there is dehydration. So IV fluids, that is the normal saline, has to be supplemented, and there is hypokalemia. So you need to correct the hypokalemia with the help of supplementation of potassium chloride. And you also need to enhance the elimination. Enhancing the elimination can be done by urinary alkalinization. Right, urinary alkalinization has to be done, and this the substance which is required for urinary alkalinization is the sodium bicarbonate. So sodium bicarbonate has to be given to alkalinize the urine. And what should be the urinary pH whenever you are giving sodium bicarbonate? The urinary pH, it should be more than 7.5, right? And next is the indication of the hemodialysis. In case of severe cases, like for suppose if the salicylate levels, right, if the salicylate levels, if they are more than 100 milligrams per deciliter, that is the point when you need to do the hemodialysis, right? So now that is in acute cases, when the levels of the salicylate is more than 100 milligrams per deciliter. In such case, the hemodialysis has to be done, right? Then symptomatic treatment. These patients, they are having fever, so you need to give the antipyretics, that is paracetamol can be given in order to reduce the fever. And these patients, they will also have seizures. Anti-epileptic drugs should be given, right? And you need to monitor the arterial blood gas analysis to check for the acidotic component, and you also need to check for the vitals, that is respiratory rate, blood pressure, and as well as the heart rate, and estimation of the levels of the salicylate is also very much essential. So this is about the story related to the salicylate toxicity clinical manifestations and as well as the treatment, right? Coming on to the next question. A 21-year young female was brought to the emergency department with a history of unknown substance ingestion. She was having vomiting, profuse diarrhea, bronchoria, excessive sweating. On examination, meiosis and muscular fasciculations were present. What is the most likely diagnosis? Corrosive substance poisoning, aluminium phosphide poisoning, zinc phosphide poisoning, then the organophosphorus poisoning. So all the secretions are increased, like there is vomiting, there is increased gastrointestinal motility, there is increased respiratory secretion, there is also profuse sweating, and on examination the eyes are showing meiosis and there is fasciculation. So all these are points suggestive of the organophosphorus poisoning, right? Now in case of the organophosphorus poisoning, so basically what are these organophosphorus compounds? These are the group of chemicals which are commonly used in agriculture as the pesticides. And how do they function? These organophosphorus poisonings or organophosphorus compounds, they inhibit the acetylcholine esterase, right? They inhibit the acetylcholine esterase, which is an enzyme essential for proper functioning of the nervous system, right? Now, because this enzyme is being inhibited, what will happen? The acetylcholine, it has to be metabolized in the presence of acetylcholine esterase enzyme. This will break down into acetyl plus choline. Now, once this enzyme is inhibited, the acetylcholine, it will not be metabolized to acetyl plus choline. So the levels of the acetylcholine, they are elevated. So this will lead to accumulation of the acetylcholine, and this acetylcholine is the one which will cause the overstimulation of the cholinergic receptors. Right, this will cause the overstimulation of the cholinergic receptors, causing the toxic effects. Now, what are the common organophosphorus compounds? These are all the examples of the organophosphorus compounds: malathion, parathion, diazinon, chlorpyrifos, dimethoate, phentheon, dichlorvos, and as well as the phorate. So these are the common organophosphorus compounds, and because of this organophosphorus compound poisoning, there will be muscarinic effects. Right, there will be muscarinic effects, there will be nicotinic effects, and there will be also central nervous system manifestations. Now, what are the muscarinic effects? In muscarinic effects, all the secretions, they increase: salivation, lacrimation, urination, diarrhea, gastrointestinal cramps, emesis, bronchoria, bronchospasm, bradycardia, and meiosis. These are all the muscarinic effects of the organophosphorus poisoning. Then what are the nicotinic effects? That is mainly fasciculations, right? Muscle twitch, fasciculation, muscle weakness, and paralysis. And once these patients develop nicotinic effects, in case of organophosphorus poisoning, they are considered to be the one with poor prognosis. This is very, very important. Then what are the central nervous system manifestations? That includes anxiety, confusion, ataxia, tremors, seizures, and finally the individual will end up in coma. Then how is that you treat the patients with the organophosphorus poisoning? So first and foremost, the decontamination. So decontamination is that because these are pesticides, like where they are exposed in the agriculture, so you need to remove the clothing. right? You need to remove the clothing and wash the skin with soap and water to reduce the absorption of the poisoning. Okay, remove the clothing and wash the skin with soap and as well as water to reduce the further absorption of the poisoning. Then gastric lavage can be done, right? So this gastric lavage should be considered if ingestion occurred within last hour. That means within 1 hour you can do the gastric lavage. And activated charcoal may be administered if within the first hour post ingestion. That means like the patient has presented to the hospital after 1 hour, right? Then activated charcoal has to be administered. Supportive care is important because the airway management. Now why is this airway management important? Because these patients, they are having bronchoria. These patients, they are having bronchospasm. So that is the reason why the airway management is very important. So you need to ensure that the airway is patent and you need to provide the oxygen. And once the individual goes into a state of respiratory failure, in this case, you need to put the patient on mechanical ventilator, right? So if needed, the patient has to be placed on mechanical ventilator if he develops respiratory failure. Then you take the antidotes. The very important antidote is the atropine. Atropine is what? It is anti-muscarinic agent that blocks the effects of the acetylcholine at muscarinic receptors. And what is the dosage of this particular atropine is? The initial dosage you need to give 1 to 2 milligrams IV. Okay, so this will neutralize the muscarinic effects of the acetylcholine, and this has to be repeated every 5 to 15 minutes. Right, this has to be repeated every 5 to 15 minutes until drying of the bronchial secretions. Right, until the drying of the bronchial secretions and adequate ventilation is achieved. Right, and another important example is the pralidoxime. So pralidoxime, what it will do is it will activate the acetylcholine esterase enzyme, right? So it will reactivate the acetylcholine esterase by cleaving the phosphate ester bond between the enzyme and organophosphate. And the dosage of this pralidoxime is like you need to give 1 to 2 grams intravenously over 30 minutes. Okay, so this is the dosage of the pralidoxime, right? And so initially you need to give 1 to 2 grams intravenously over 30 minutes, and this should be followed by 0.5 grams per hour. That is about the pralidoxime. Next is benzodiazepines. Why is that you need to give benzodiazepines? Is mainly to control the CNS manifestations, that is mainly for the seizure control. We give the benzodiazepines, right? And the common choices are diazepam or lorazepam is being given. Fluid and electrolytes. So you need to correct any dehydration if present. Okay, and for that you need to give normal saline because these patients, they have diarrhea, so there is chance of the dehydration, right? And you also need to correct the electrolyte imbalances because there is diarrhea in these patients. And you need to monitor the vital signs. So monitoring of the vital signs, that includes the respiratory rate, blood pressure, heart rate. So these are like monitoring of the vital signs, where you need to do regular monitoring of the heart rate, respiratory rate, blood pressure and oxygen saturation. Okay, so this is about the treatment of the organophosphorus poisoning. So the key points here are the early intervention should be done with the help of atropine and as well as pralidoxime. That will significantly improve the outcome of the patient. Supportive care is very much crucial, right? And decontamination and appropriate use of antidotes, they are essential to prevent further absorption and mitigate the effects of the organophosphorus poisoning. So this is about the organophosphorus poisoning. So the next important question in the toxicology is, we have a young female of 22-year-old presented to the medical emergency with complaints of nausea, vomiting, abdominal pain, diarrhea and convulsions along with methemoglobinemia. What is the likely diagnosis? The options are aluminium phosphide poisoning, zinc phosphide poisoning, copper sulfate poisoning, lead poisoning. So the correct answer here is the aluminium phosphide poisoning, the one which is associated with the formation of the methemoglobinemia. What exactly is that? I'll be discussing. Now, if you take this aluminium phosphide, it is a highly toxic compound often used as a fumigant pesticide, right? Often used as the fumigant pesticide, and this aluminium phosphide, it releases gas, that is phosgene gas, upon contact with the moisture, right? So upon contact with the moisture, the aluminium phosphide, it will release the phosgene gas, and this phosgene gas, it is a highly toxic agent. And what exactly the phosgene gas does? The phosgene gas, it inhibits the cellular respiration, right? It inhibits the cellular respiration by disrupting the mitochondrial function, right? By disrupting the mitochondrial function. And once the respiration is being inhibited, there will be respiratory failure, and this respiratory failure is the one which will lead to multi-organ dysfunction, right? So this will lead to the development of the multi-organ dysfunction. Now, what are the features of the aluminium phosphide poisoning? If you take the gastrointestinal manifestations, that includes nausea, vomiting, and as well as the abdominal pain. Then what are the cardiovascular system manifestations? These patients, they will develop either tachy, right, or bradycardia, and consequent to that, there will be hypotension, and these patients, they also develop the cardiac arrhythmias, right? These patients, they also develop the cardiac arrhythmias, right? And there will be also the myocardial depression. Respiratory symptoms include the development of dyspnea, and this particular dyspnea, it is secondary to the development of the pulmonary edema, and there will be respiratory distress. And neurological symptoms, that includes the headache, dizziness, and the individual will be in a state of altered mental status, right? Altered mental status, and then development of the seizures. So these will be the neurological symptoms. Then what are the metabolic symptoms? Metabolic symptoms include the development of the metabolic acidosis and as well as the headache. So, and there will be hypoxia. So these are the systemic manifestations. Then how is that you will treat the aluminium phosphide poisoning? So the immediate action is you need to remove the individual from the exposure. So you ensure the patient is moved to a well ventilated area or the fresh air, right? He is moved to a well ventilated area or to a fresh air. Then you need to do decontamination. Now, if the ingestion, if it is a recent ingestion, then you can consider for the gastric lavage. But this gastric lavage, whatever you do, right, the gastric lavage, it should be done with caution. Why? Due to risk of perforation and further exposure to the phosphine gas, right? And activated charcoal, it is generally not effective in case of the aluminium phosphide poisoning. So gastric lavage can be done, but that should be done with caution due to risk of perforation and further exposure to the phosphine gas. Then the airway management. In the supportive care, airway management. So you need to secure the airway and provide the supplemental oxygen, right? And in severe cases, you need to put the patient on mechanical ventilation or mechanical ventilator. That may be necessary in severe cases. Next is the circulatory support, right? So circulatory support is that you need to give IV fluids to maintain the blood pressure. So in order to manage the hypotension, aggressive fluid resuscitation with isotonic fluids, that is the normal saline, has to be given. And with normal saline, if the blood pressure is not improving, then you need to use vasopressors, right? You need to use the vasopressors. And this particular vasopressors, example, they include norepinephrine and as well as dopamine. So this vasopressors have to be administered if the hypotension persists despite adequate fluid resuscitation. Then cardiac monitoring should be done with the help of the ECG, right? So continuous ECG monitoring, that is due to risk of the arrhythmias, right? And you also need to treat the arrhythmias according to the ACLS protocol. So if there is development of arrhythmias, you need to treat the arrhythmias according to the advanced cardiac life support protocol. Then you need to correct the metabolic acidosis. The correction of the metabolic acidosis should be done by the administration of the sodium bicarbonate. And if the acidosis is severe, when the pH is less than 7.1, then you need to administer sodium bicarbonate. Next is the supplementation of the magnesium sulfate. Some evidence suggests that magnesium sulfate may have protective effect on the myocardium. So this magnesium sulfate, it will protect the myocardium, right? It will protect the myocardium, and as well as the magnesium sulfate will also treat the arrhythmias, right? Will also treat the arrhythmias. Okay, and what is the typical dosing? 1 to 2 grams intravenously over 10 to 15 minutes. That is magnesium sulfate. The antioxidants should be supplemented, that is vitamin C, and as well as the N-acetylcysteine that may be considered for their antioxidant property. So antioxidants have to be supplemented. Then, so this will be like supportive care. But if you take the advanced treatment, the advanced treatment include ECMO, that is extracorporeal membrane oxygenation. In cases of severe cardiopulmonary failure, right, in cases of severe cardiopulmonary failure, right, in these cases the ECMO may be considered as a bridge to recovery. Then next is hemodialysis. Although not effective in removing the phosphine gas, hemodialysis can be useful for managing the severe acidosis. So to manage the severe acidosis refractory to sodium bicarbonate and to manage the renal failure and the respective electrolyte abnormality, the hemodialysis should be done. It is not for removing the phosphine gas, it is for managing the severe acidosis and as well as the renal failure. So this is about the aluminium phosphide poisoning, right? Next question. In a children with high anion gap metabolic acidosis, poisoning with which of the following may be suspected? Iron, methanol, rifampicin, beta blocker. So it is the methanol where you have high anion gap metabolic acidosis, that is called the 𝐒𝐲𝐫. So how is that? Okay, what is the normal anion gap? That is around 8 to 12 milliequivalents per liter. And the anion gap we usually calculate in individuals with metabolic acidosis. And how is that we calculate the anion gap? So anion gap, it is calculated as sodium minus chloride plus bicarbonate levels. So this is what is the anion gap. That should be calculated in individuals with metabolic acidosis. And there are certain conditions where you have high anion gap metabolic acidosis, and there are certain conditions where you have normal anion gap metabolic acidosis. So you have either 𝐒𝐲𝐫 or the 𝐛𝐬𝐫. So you take the conditions where there is elevated anion gap. Examples of the conditions where you have elevated anion gap, that example is the, just please remember this mnemonic, that is mud piles. M stands for methanol and metformin intoxication, U is uremia, D stands for diabetic ketoacidosis. And piles like that is paraldehyde and fenformin, isoniazid or the iron supplementation, lactic acidosis, ethylene glycol intoxication and ethanol intoxication, and as well as the salicylate poisoning. So these are the conditions where you have elevated anion gap. Then what are the conditions where you have normal anion gap? That is, just please remember the mnemonic, that is used car. Examples, U stands for ureteral diversion, S is saline infusion, E stands for exogenous acid supplementation, diarrhea, carbonic anhydrase inhibitors, adrenal insufficiency, and then renal tubular acidosis. These are all the conditions where you have normal anion gap metabolic acidosis, right? So that was the question where you have 𝐒𝐲𝐫 and 𝐛𝐬𝐫. Next question. Urinary alkalinization is used for enhancing the excretion of which of the following poisoning? Phenobarbital, alprazolam, phenytoin, and as well as the lithium. So urinary alkalinization, it is a therapeutic strategy used to enhance the excretion of certain poisonings and drugs that are usually weak acids. These weak acids, they have to be eliminated by the process of urinary alkalinization. Now, in case of urinary alkalinization, what is that you do? You will increase, right? You will increase the pH of the urine, right? By increasing the pH of the urine, these weak acids, they become more ionized and less absorbed in the renal tubules, thereby promoting their elimination from the body. That is what you do. And among the options which has been given to you, your phenobarbital, that is a weak acid, and for elimination of this phenobarbital, you require the urinary alkalinization, right? So poisonings and drugs for which urinary alkalinization is required. So, okay. So urinary alkalinization is what? It is this procedure in which there is enhanced excretion of certain poisons and drugs, which are the weak acids, right? Which are the weak acids. And what exactly you do here, right? By increasing the pH of the urine, the weak acids, right? These weak acids, they become more ionized, right? They become more ionized and they are less absorbed, right? They are less absorbed across the renal tubule. Once they are less absorbed across the renal tubule, that will cause the promotion of their elimination from their body, right? And that is the mechanism. The mechanism is that they become more ionized and they will not be reabsorbed across the renal tubules and thereby eliminating from the body. Now, what are the drugs which are excreted by the urinary alkalinization? One is your aspirin, that is the salicylate, then phenobarbital, right? The phenobarbital. Then next important is methotrexate. Methotrexate is a drug used in the treatment of rheumatoid arthritis. Then chlorpropamide. What is chlorpropamide? Chlorpropamide, it is the first generation sulfonylurea, right? And how is this urinary alkalinization being done? That is by giving intravenous sodium bicarbonate. And there are certain contraindications for urinary alkalinization. Like if there is renal impairment, right, then urinary alkalinization should not be done. Then followed by that, if there is volume overload, then also the urinary alkalinization should not be done. Okay, so this is about the story related to the urinary alkalinization, right? Next question. Okay, so the next one is a repeat question. A 4-year-old child is brought with a history of ingestion of 1 gram of paracetamol 2 hours back. What should be the best management? So 2 hours is over, right? So thereby the gastric emptying also might have been done with the patient. So doing the gastric lavage or inducing the vomiting will be of no use. So what is that you need to give in these patients? That is oral N-acetylcysteine has to be administered in this patient. And this oral administration of N-acetylcysteine can be done within 8 to 10 hours of the ingestion, right? And ideally as soon as possible. So this helps in preventing the potential liver damage. This helps in preventing the potential liver damage due to paracetamol toxicity, right? Next, antidote to reverse the muscarinic effects of the organophosphate toxicity is, so pyridoxine, atropine, adrenaline, N-acetylcysteine, right? So what is that? It is the atropine which will neutralize the muscarinic effect. Next question. Which of the following statements are correct regarding the scorpion stings? Options: scorpion injects venom from the stinger on their nail. This is the correct statement. Most stings are painful but relatively harmless. This is little question mark because they are harmful. Anticholinergics can be used if antivenom is unavailable. That is the correct statement. So the answer is 1 and 3. Right, 1 and 3. Most scorpion stings, they are indeed very painful, but they can vary in severity depending on factors such as species of the scorpion and individual's reaction to the venom, right? So we cannot say they are completely harmless, right? We cannot say they are completely harmless. Okay, many of the scorpion stings may be relatively harmless, but some species, they cause serious symptoms, especially in children and individuals with underlying health conditions. And anticholinergic can be used if antivenom is unavailable, and the purpose of giving this anticholinergic is it will manage the symptoms such as if there is any excessive salivation, right? If there is any excessive salivation, the anticholinergic will reduce the salivation, right? And if there is profuse sweating, the anticholinergic that will be very much useful. And if there is bronchospasm, right, the anticholinergics, they will be of use. So this is about the scorpion sting, right? Next question. Exchange transfusion as a method to enhance the excretion of poison is indicated in methemoglobinemia, carbamazepine poisoning, theophylline poisoning, then barbiturate poisoning. So exchange transfusion, it is required in case of the methemoglobinemia, right? Methemoglobinemia, it's a condition which is characterized by elevated levels of methemoglobin in the blood, and this methemoglobin, it's a form of hemoglobin, right? It is a form of hemoglobin in which, right, in which the iron atom, right, iron atom in the heme group, right, the iron atom in heme group, it is in the ferric state, right? It is in ferric state rather than the normal ferrous state. Okay, so normally it is the ferrous state. The iron is present in ferrous state in the heme component of the hemoglobin, but instead of Fe plus 2, if Fe plus 3 is there, then we call it as methemoglobin, right? So what will be the treatment for the methemoglobinemia? First and foremost, discontinue the exposure. If methemoglobinemia is due to exposure to a specific oxidizing agent, right, if it is due to exposure to the specific oxidizing agent, then in such case the first step is to remove the individual from further exposure to the substance. Okay, next is the supplemental oxygen. Providing supplemental oxygen, it helps to improve the oxygen delivery to the tissues, and it can be beneficial. Okay, and this supplemental oxygen, it is especially useful in cases of mild to moderate methemoglobinemia, right? So in case of mild to moderate methemoglobinemia, supplemental oxygen is required. So this supplemental oxygen, it helps improve the oxygen delivery to the tissues. Next is the methylene blue. Methylene blue is a medication that can rapidly reduce methemoglobin level by converting it back to the functional hemoglobin. Okay, so what it will do? It will reduce the methemoglobin levels. It will reduce the methemoglobin levels. And how is it administered? It is administered intravenously. And what is the dosage of this methylene blue? The dosage of methylene blue is 1 to 2 milligram per kg of the body weight, and this has to be administered over 5 minutes. This has to be administered over 5 minutes. But please remember, this methylene blue, it is contraindicated in individuals, right? It is contraindicated in individuals with G6PD deficiency due to risk of the hemolytic anemias. So in patients with G6PD deficiency, you cannot give the methylene blue, right? Because there will be risk of the hemolytic anemias. Then the ascorbic acid, that is vitamin C, it has been used as an alternative treatment for the methemoglobinemia, right? Ascorbic acid has been used as an alternative treatment for the methemoglobinemia. Particularly in cases where methylene blue is contraindicated or unavailable, this ascorbic acid is being used. And this ascorbic acid, that is vitamin C, this will act as reducing agent. right? This will act as the reducing agent and it can help to reduce the methemoglobin levels, right? So however, its efficacy in severe cases of methemoglobinemia is limited compared to the methylene blue, right? So the efficacy wise, it is not that great as that of the methylene blue, but methylene blue, wherever it is contraindicated, then you can give the ascorbic acid. Next is our question, that is exchange transfusion. In severe cases of methemoglobinemia or when other treatments are ineffective, the exchange transfusion can be considered, right? So what this involves replacing the patient's blood okay, this involves replacing the patient's blood with donor blood to reduce the methemoglobin levels. So that is about the exchange transfusion, and you need to treat the underlying cause. So identifying and treating the underlying cause of methemoglobinemia is essential for long-term management. This may involve discontinuing the medication, right? Discontinuing the medication, and you need to address the environmental exposure. So this is about the treatment of the methemoglobinemia, right? Next question. In case of a child with acute poisoning by ingestion, activated charcoal may be used in which of the following situations? Iron ingestion, anti-epileptic ingestion, corrosive ingestion, and lithium ingestion. So in case of anti-epileptic ingestion, the activated charcoal may be used. Activated charcoal can be effective for certain anti-epileptic drugs. What are the anti-epileptic drugs for which the activated charcoal is effective? That includes phenytoin, that includes carbamazepine, and that includes the phenobarbital, right? That includes the phenobarbital. Okay, so in these three anti-epileptic drug toxicity, the activated charcoal, that is very much useful, right? So the answer is second option. These are some of the previous year questions on the topic of the toxicology. With this, the quick revision of the toxicology is done. Thank you very much.